Welcome, everybody, to the Health Impact continuation of some of our discussions about wellness. It's been a struggle every time we talk about wellness during the pandemic or talk about anything other than COVID, where people are saying, well, no, the pandemic is most important and fighting the coronavirus is most important. And of course, that's very, very true. The problem is that wellness has never been more important because of the coronavirus, because of what we're doing with COVID. So here, I'm really, really excited to have Dr. Bryant Adebayo to come talk to us about what he sees wellness means, and as Assistant Vice President at Rush Medical Center, including being the Chief Wellness Officer. Not only does he have a lot of opinionated and provocative viewpoints, but he's got some really good advice for leaders about what you should be doing right now, both from a prioritization perspective as well as from a focus perspective. So you can still prioritize COVID, but focus on certain sections of wellness. And this might be even more important for care providers' wellness in addition to patient wellness. So I'm sure, hopefully, Bryant will talk about that as well. But without further ado, Bryant, take over. Tell us a little bit about yourself, what you do at Rush, and then what do you think about wellness and how we should take into account today?
Sure. Well, thank you so much for the intro, Shahid. And my first recommendation is going to be to get a fedora and a vest just like you. We all need to take some style tips, but in all seriousness, appreciate the introduction. It's certainly a privilege to be here. So I am, as you mentioned, System Vice President and Chief Wellness Officer for the Rush University System for Health in Chicago, Illinois. I'm also a professor of organizational change and leadership offsite at the University of Southern California, where a lot of the work that we're talking about will tie in as well. So without further ado, Shahid, I'll go ahead and jump in. Let's go ahead and jump in. So our talk here is entitled Creating Wellness in a Pandemic. My goal very briefly is just to go over three main points. So first, an overview of what's happening and how we should be thinking about wellness from the health systems level, particularly as we continue to combat this pandemic and transition very soon into the fall flu season. We'll address some myths and misconceptions and also introduce some data and some frameworks. And we'll end with the case study. And Shahid, please feel free to pop in and interrupt with questions and comments as we go along.
Will do.
So let's start with an overview then. So first, this is a great graphic that I saw online, and this is just a conceptual framework. This isn't based on any empiric work, but I thought it was a great way for us as health system leaders to think about really what's happening and what's the inevitable impact of COVID. And Shahid, I think, as you mentioned, and really understanding the psychological and the emotional well-being toll that this pandemic can and is having on all of our health systems. So in this graphic, you'll see four different waves that have been interpreted as taking place as part of this pandemic. With this first purple wave, we think about the immediate impact, right? You can think of this as the surge, right, as we responded to those. In a second wave, you think about the impact of resource restriction on some of those urgent but non-COVID related conditions. So for any health systems leaders, we certainly went through this wave here in Chicago, and for others who are either there or will be soon, we certainly saw this with our non-COVID GMF census increasing. You think about this third wave, so its impact on our chronic care conditions. So you think about our cancer and other patients. Our focus today will really be on this fourth wave. So the overall impact from a psychological trauma, mental illness, and burnout, which we see again increasing over time as part of this. And so wanted to use this to set the stage for some of our conversation. And I'll just briefly touch on this. Many people have seen this slide, and I've certainly seen it in some great talks that I've been able to witness as well. But just very quickly wanted to show some of what we think of as the phases of disaster. And as health system leaders, I certainly think we should think of the different phases that our own employees and staff may be going through as part of this. So you think about the pre-disaster phase, so that's the anticipation that we know this is coming. The impact phase, so the direct impact of the pandemic. This could be the surge. This could be the ongoing evolution of this of the situation. I think we all certainly can recognize the heroic or the healthcare hero phase, in which there is really wide support and wide buy-in from across the institution, in which there's really that community support. This is followed by a very short phase known as community cohesion and the honeymoon phase. This is where there are wide, ample resources available, state, federal, local, and otherwise, and tremendous input for those who have been or are going through the process of a true surge as we speak, this is also where there might be ample staff from a redeployment standpoint that are available to be seen across the health system. This is immediately followed by the period of disillusionment, though, right, in which we often think of this as the phase in which the adrenaline has worn off, the reality has set in on the limitations of the resources that are available, and it's tough, right? And as you can see along the bottom there with the trigger events that can occur, this is a period of emotional lows in which burnout and some of the other factors that we mentioned earlier, the emotional traumas and others that psychic traumas that can occur take place. But all throughout, the whole concept here is that we are ultimately moving to a place of reconstruction in which we're able to develop a much higher degree of resilience and things going forward. So I always like at least demonstrating these two slides to help level set, and also as health leaders to begin to navigate where we are as an institution, where we are potentially as a department, and where we are personally. This framework was really built for really more of a direct impact type thing, right? An act of nature, a national tragedy that's occurred, a singular point. But what we find ourselves in is in an evolving situation. And so it's difficult to map, but it does still at least give us some idea of some of the psychological stages that we go through following something of this nature. One of the first things I want to just start with is a reframing. So there's something I commonly hear, and obviously as Chief Wellness Officer, I have my own perspectives on this, but I want to propose something that might be a little opposite of what many are used to or have certainly considered. You commonly hear the terms health and wellness, and the terms are used somewhat synonymously, health and wellness, used almost as if they're one and the same. And one of the first myths and misconceptions I want to propose to this group today is that they're not the same. They're certainly not the same. And I don't mean that as a matter of semantics. I mean that from a very practical standpoint and from the standpoint of how we approach building this within our institutions. So we give some examples here, and I'll build on this as a foundation. So the two terms are interrelated, codependent, certainly over the long term, but they are distinct. And I give an example. So first, someone can be healthy, but unwell. An example I'll give there is, to me, that is quite literally burnout. And I know there have been some other great talks today already speaking about burnout, so I won't go into that, but I think this is one that certainly everyone that's part of this conference can relate to. You're healthy, you maybe are not necessarily in a great state of wellness, and as a result of that, we inevitably lead to burnout. Next, we have those who may be unhealthy, right, but are well. And the example we give here are the tremendous amount of courage and just tremendous amount of grit and resilience that those who may be at the end of life, or those facing a serious illness may incur, where they are not physically healthy, but they are balanced, they are at peace with themselves and their families, have identified their overall sense of purpose, and have really demonstrated a tremendous amount of well-being in the face of really challenging physical odds. And then finally, the ideal state is that you have both, that you're both healthy and have a tremendous sense of well-being. We think of this now as a continuation of that. As I speak to many of my colleagues at other institutions and either other organizations following our case studies publication that we're looking to build similar frameworks, they'd often say to me, well, Dr. A, we need to build healing in our institution following COVID or even during COVID. We really need to heal and really think about a comprehensive wellness program. And with that same mindset that we used on the last misconception, I'd say healing and wellness are also not one and the same. Using our same model here, the two are interrelated, they're codependent, but they are distinct. So in the first case, someone can be healing but unwell. And in that example, I use is injury. So think about the professional athlete who is physically healthy, in great shape, has maybe had a devastating injury and now are facing a crisis of identity, of purpose. They are anxious and eager and ready to get back, but ultimately are not in a great state of well-being. In the second example, we think about our colleagues or those we know who may have a disability, who may be physically disabled and are unable to heal in the traditional context, but have a tremendous amount of purpose, are showing an incredible amount of resilience and grit and are an inspiration to all of us and are incredibly well. And then the final example I give is in the previous is that we have both. We are both healing and in a state of well-being in which we have an accelerated amount of healing and increased resilience. So one of the first recommendations that I want to make as part of this talk is that we shift from this concept of looking to heal our communities following COVID or because of COVID or just in general, following the many challenges that we face in healthcare, and instead shift to a focus on building community resilience as really a key element there.
So do you have an example of what one might mean there?
Oh yeah, and it's actually on this slide right here, Shahid, and I'll provide several more than maybe you'd even like to know. So my final, again, building on these three-tier foundation that'll really anchor this talk, is this final misconception is when I say now build community resilience, it's this idea that another term or terms that we commonly hear synonymously is that well-being and resilience are one and the same, particularly within our communities. So again, continuing with our model here, and I would posit here that these two again are interrelated, codependent, but distinct. Well-being refers to a state and usually refers to a current state that is evaluated based on perception and is subjective by its very nature, right? We evaluate our well-being by evaluating how we are reacting to our current state. Resilience, by comparison, are a set of processes, right? It is future leading, right? So similarly, I'm speaking to you from our new Rush Center for Clinical Wellness, which is really just a tremendous facility and amenity that we've built for our community here. And part of our goal is, as members of our community, our physician staff, for example, come in, we want to develop the processes that they need to create that future state of well-being, one of which, a key one, is an adaptive capacity, which is certainly necessary following the circumstances that we face. Some examples here. On the well-being side, you can think about your community's economic, social, or environmental wellness. But resilience focuses on things like strategic thinking, your ability to mobilize resources. You may not be a huge health system. You may not even have a wellness department, but your ability to mobilize what resources you do have will impact your ability to adapt. And then finally, the ability to bring people together around a collective efficacy. So these two, while absolutely interrelated, are distinct. And this is really where I wanted to demonstrate. If we think about this from an overall frame, and I'll just touch on this for a second. On the far left, you'll see impacts of change. Think COVID. Community resources. Think of all the limited resources that exist within your health system. These are split between these two key dimensions, as I mentioned. Well-being on the top, right? And you see some of the parameters there. Again, these are broad in reference to a general state, right? What is the state of the environmental wellness of your facility or health system? But resilience really focuses on these key processes over which we can really build these apparatus into our work, the strategic thinking, the leading, effective use of our resources, and as I mentioned, commitment and our collective efficacy, all of which funnel into this future state of well-being. And so a big part of what I would like to posit as part of this talk today is most organizations, most health systems focus on the wellness. They say, you know what, we're going to focus on improving that current state. What is the reality and the perception that we face now? I argue that we should focus on building the community resilience. It has a greater impact on our future state of wellness, and it also creates the mechanisms that allow us to build and incorporate wellness in an ongoing fashion. Interrelated, codependent, but distinct. Distinct in
How
how we
complex is
put our
this?
attention.
So how
I actually think
complex
it's
is this? How
relative.
long does it take?
Yeah, well, when we talk about building a future state of wellness, we are talking about something that's cultural in nature. It takes time. And certainly when you look at the resilience dimensions that we mentioned here and that I'll kind of speak to on the next slide, there are some specific actions that we can take. It will take time though. And I think that's part of the investment that health systems and health leaders need to be prepared to make. And it's also a paradigm shift, right? From this idea that, you know what, you're on your own. Think of this as the 20 to 30,000 foot view, then this would be us punching in just a bit more onto the community well-being and resilience dimensions. What this shows is all the solid lines are those that in this study were statistically significant to the area that they're pointing to. So solid lines, really impactful, dotted lines, less so. There are a few of these under the dimensions that are obvious to us, right? So someone's personal safety is always going to be an important part of their overall sense of well-being, but there's some that are less so. So we often think about the economics, right? Including how and when we pay folks as a big part of their overall sense of well-being. Certainly is, but a lot of what the literature that's presented here demonstrates is that maps more to individual well-being and less to the overall community sense of well-being, which is a short way of saying there are certain dimensions that impact us at a community wellness standpoint, which can trickle down to our individual wellness, but it doesn't necessarily work in the opposite direction. That is, things that impact us individually don't necessarily contribute to the greater overall. The biggest thing that I want to draw attention to on this slide are two pieces, which is one, that overall community spirit and cohesion. That is how well we can come together and I can feel that I can rely on my colleague. How well do I feel that I can rely on Shahid or someone else who might be listening in to help in the event that something happens, is the greatest overall driver of that community well-being. Whereas on the resilience side, it's that sense of community decision-making and trust, that word and trust, that I feel that my voice can be heard. I feel that I understand where the decisions are happening. For those who have command centers and a central command that's responding to this COVID-19, what that means is to build that sense of resilience, you need to create a mechanism whereby the voices from your community can be part of that central decision making. And in our case study, I'll provide a specific example of how to do that. So finally, I'll end here and then we'll transition to our final slides on the case study. Some simple recommendations to consider, especially as we move forward and transition into this fall period, knowing that we'll likely have some additional challenges as we evolve in this pandemic. The first, as I mentioned, was to shift from this idea of healing and healing the community to really building the sense of community resilience. Within resilience, and Shahid, I think this answers one of your earlier questions about the how. There's a few specific things that we can focus on. The first is community decision-making and trust, as I mentioned, getting the buy-in, making sure that people have a clear idea of how decisions are reached, that they have a mechanism for how their voices can be heard, and that we're really making that idea of community trust a priority. Also on the well-being side, focusing on that sense of community spirit and cohesion, that ability to come together around that common cause. And then some secondary focal items that I list there that are equally important for us to consider. I'll add, here in Rush Wellness, we really try to work through three primary guiding principles. Those are simplicity, clarity, and execution. So even if you don't have the time to read the paper or maybe don't even have the interest, let's make it really simple. Instead of focusing on, this immediate state of well-being, how do I kind of respond or react rather to this pandemic and make sure my staff is well? Build in the processes that'll create wellness going forward. Because even though COVID-19 is a major issue that we're facing now, right? In July of 2020, in July of 2021, there will be some other challenge facing healthcare. It may still be COVID, it may be something else, right? So part of what I'm arguing for is if we redefine how we look at wellness and begin to think of it instead as a set of processes that creates a future state, focus on our adaptive capacity, that will enable us as a health system to be more ready for the future and to build in that sense of resilience as we go. I think that's really the key takeaway from this talk today.
Yeah, that's great.
So if we jump into our case study, so we, again, I want to articulate a little bit of how we use the same frameworks that I described earlier in a real world example. So in creating wellness in a pandemic, early on in this scenario, I realized there really wasn't a clear guide that myself as a health system leader could use. There was some great literature that was published that really gave frameworks and things around what we should consider, great examples at the individual level, but no overarching framework that helped tie it together as a health system. And so we created one, which was a 4-part strategy to help respond to well-being during this pandemic. The first of which we call wellness rounds, which was started through a central wellness task force in which we looked at a cross-section of departments across our health system that really we brought together to the table. Again, that focus on community decision-making and trust. As a task force and as a body, we determined that there was really a tremendous need for a focus on our employees. And so wellness rounds are exactly that. Instead of rounding on our patients and others as we normally would, we sent into our critical care units, our ICUs and otherwise, psychiatrists and psychologists and licensed clinical social workers and chaplains and nurses and an interdisciplinary team that was tasked with doing nothing other than checking in on our staff. And they were able to screen if there were issues or problems. And they formed a two-way route of communication that allowed us to get information from the front lines rapidly into our command center and allowed information from our command center to be rapidly disseminated using this, what we called our wellness response team. And actually in this photo, what you'll see here is it's me in the center in the middle of our huddle. To my right is actually our system CEO who's joining me as we're working with our wellness response team and hearing some of the issues that they have encountered on the units and making real-time decisions to help enable our staff to continue the great work that they do. So wellness rounds was a crucial part of our 4-part strategy, in part because we had the exact same team round on the exact same units. We met at the exact same times. And while many institutions have instituted rounding of some sort, we went through a formal onboarding and training process that I'll get to on the next slide that standardized the experience that each of these staff members would have on the units to ensure that we were wellness forward and able to rapidly meet the needs of our community. So wellness rounds was one of 4.
Did the wellness rounds freak anybody out?
Oh yeah. So we talk about this in the case study, right? So, you talk about lessons learned, right? Things that went well and things that maybe didn't go well. This did not work at first, I'll be completely honest with you, right?
Yeah,
so this
that's
idea
what I wanted
of
you to tell us.
this, I wish I could say to this, to you and to the crowd that it was a smash hit, right, when we started. Just the opposite. I think clinical units were a bit, rightly so, suspicious of who these folks were and how this was going to work, and I think the team was maybe a little nervous and demoralized the first time around. But as I mentioned, the key was consistency. So as we kept coming back, as we kept checking in on staff, some of this goes back to what I said, right? This idea that self-care and healthcare is still a new concept. And once they realized that our sole purpose was to check on them, to listen before speaking and see if there really was a need that they had, then I got to tell you, as we kind of got through the surge and started to return to a certain degree of normalcy, the number one complaint we had was, the wellness team can't leave. It's the best part of my day. I look forward to it. And anytime you're having a tough day, it's always great to join wellness rounds and to get outside of yourself and take care of others. So it's really been a great success story that we're really proud of being able to help our staff with that.
That's awesome.
We keep rolling there. We also launched, and we realized people needed a place to go. So, we created a wellness resource hub. Think of this as a pop-up central wellness space. It was staffed with our mental health providers. It had comfy chairs. The photo on the left shows you we had a kind of a waterfall with some calming music playing and some nice chairs and lounge chairs where folks could relax and have a healthy snack. It was a place where people could leave the unit and get that sense of space, mindfulness, and meditation. We also had psychologists and social workers there ready, licensed clinical social workers there ready, if they needed to talk through and process some of what they were encountering. Not everybody can leave the units, and so we used a hub and spokes model where this resource hub was quite literally in the center, an easily accessible location, but also we had a series, the spokes, on the actual COVID units in which staff who needed to step out for a moment could spend that time. And that's what's demonstrated here through the wellness room there on the right. So this was, in the first, think of this as the infrastructure, and the second strategy was really the physical structures that we put in place to provide that response.
Just a quick question about that. How does that differ from just the staff lounge?
Oh, very different. So a few things. So number one, we have a number of healthy, free, supportive snacks that are all geared towards long-term energy, right? So low on the glycemic scale, but high on the long-term energy, whole grains and things of that nature. Second thing was these spaces were specifically designed for wellness. So they were quiet. They were impactful. People could maintain social distance, but also have that sense of relief and escape. So, for anyone who's been on these clinical units and up there, you know that the staff break rooms can get a bit rowdy at times. And so this was really the antithesis of that. So, yeah. Cool. Our third piece was our wellness consult service. So again, for all the healthcare providers, and especially physicians and folks who'll be watching, the consult service is nothing new. This is something that's known. You call a cardiology consult, a GI consult. Otherwise, part of our goal was to more formally introduce the concept of wellness into the clinical environment. And so we did the same with the wellness consult, where you could page us if you yourself needed a wellness assessment. You could also page us anonymously to have us check on a colleague or staff member that you might be concerned about. We did it for individuals. We also do it for groups. And so what you see here, and Shahid, you may remember earlier I mentioned that we didn't just kind of get a team together and send them out on the units. We used a formal kind of onboarding structure and escalation pathway. We standardized our responses so we're able to ensure quality with each piece. And that's part of what you see here. So this is our wellness consult triage algorithm, and you can see it, what we do for the individual, if it's about another individual. If we get a page and that person is not at work, which you can understand is a special circumstance, and then even with at the very bottom where it says a page about a group. And SOS is a term that we use here internally at Rush, and it means support our staff, which is a group facilitated structure. But this gives you some idea of the rigor with which we approach this, so that it wasn't just a, who can respond and get up there. We had a process for ensuring consistency across our team. All right. And then on our final case here is what we call Wellness Plus, which really the summary is what I say there, which is for the rare but serious. So again, if you're going to screen an entire healthcare population, you need to be prepared to find some things that require rapid escalation and those that may be a bit more serious. And that's why we call these Wellness Plus. So, Shahid, you asked a great question on the last one, which was there any reticence to use the consult service? And part of what helped us was having that network of wellness rooms, that confidential, quiet space, allowed us to do these assessments in a place where people didn't feel that they were, being stigmatized in front of their coworkers or otherwise. We had that safe space, so to speak. And Wellness Plus was as you can see here, was, in the event that we were triaging and came across someone that could have been a threat of harm to themselves or others, or substance misuse, or just needed a higher acuity of care, we also had a pathway here that we'd use. And that bottom arrow that you see there is the process we would take for rapidly escalating, that escalation step from just the general wellness rounds, which were always wellness first, meaning we weren't just kind of walking, doing mental health screening on everyone. We were focused on their overall well-being, how we would navigate that more rapidly to a true wellness plus. And I know we don't have a whole lot of time to get into the nuances here today, but the good news is our case study, our New England Journal of Medicine Catalyst case study, goes into way more detail than you'd probably like to know, and that's where you can read a bit more. But we did want to make sure that we covered the base there. I'll add, Shahid, I think part of what you have seen is, so in the earlier slides, as we talked about the concept, it was a focus on the processes. Now, what we've shown is an example of the how, right? So if that was really the what and the why, this is really the how. So this is part of how, again, using the framework of the Comprehensive Wellness Task Force to bring people to the table, and also that democratization of the information coming from our command center. We were able to connect directly with the front lines, to where the front lines knew exactly how and why decisions were being reached out on our command center, and vice versa. And in many cases, as we would sit at the table and try to, rapidly respond to issues and PPE and patient care that was coming in quickly, we were able to say, hey, what's happening on the front lines? What are people saying? What are their concerns? And we had a mechanism for doing that, which builds that community decision-making and trust, as we mentioned earlier. So just quickly here, some simple things. One is we are a health system. So we have been able to roll this concept out across our health system, which has been great. We're also now, as I again says, I'm speaking to you from our Center for Clinical Wellness, we're able to integrate this work into this new space, ensuring that those who need to get off the unit and really spend some time here in the Wellness Center are able to do that. And then we also are screening broadly for PTSD. So any of our clinicians who visit us here and schedule an appointment in our center are auto-screened for PTSD as they meet with our providers. And we are focusing on a few different pieces here, so both counseling and just wellness coaching in general. But we want to make sure that we are screening to ensure the best practices for our folks. So finally, some recommendations to take away, I think, again, is this transition from well-being to a focus on resilience. We need to prepare for this reverse surge. And by that, I mean the psychological impact and things, especially as we head into the fall and winter, and then be prepared to support our staff from that disillusionment into that reconstruction phase.
Excellent. Well, Dr. Bryant, we definitely appreciate you coming out, talking to us about this, showing that there is a way out of the crisis if we focus on the clinicians. And what was interesting about that clinician wellness is it's actually a nice term, because it's not wellness using clinical capabilities to help patients, but the wellness of the clinicians themselves. This was just terrific, because it's a topic that I care a lot about, and something we have covered at Health Impact quite a bit. So with this, we'll let folks follow up with you with any questions, and we'll go on to the next session.
Cheers. Thank you.